I'm Ira Kirschbaum. I am the editor of the Journal for Orthopedic Experience and Innovation. Tonight, we have a session that was organically developed through a simple post by Dr. Matt Barber that went incredibly viral and had a huge number of comments, all related to dual mobility hip cups. I want to remind everybody, if you have a question, the best thing to do is to put it into the chat, and then I will call you and you will hopefully show us your video and ask your question and have a discussion with our panel. I'd like to begin by introducing the panel. I mentioned Matt first. So Matt, why don't you introduce yourself, where you've been, what you're doing? So we all know who you are, but tell us who you are.
Matt Barber. I'm in a little private practice down in Mobile, Alabama, doing hips and knees. Just got back from OSET, got to see some exciting people there. So good stuff. Looking forward to the discussion tonight.
Thank you. And we have from upstate New York, the home of the Buffalo Bills, we have Brian McGrath. Brian, you want to introduce yourself?
Yeah, hi, I'm Brian McGrath. I'm at the University of Buffalo in the Department of Orthopedics. When I started in this place, I had 8 partners and I was the youngest. Now I have 48 partners and I am the second oldest. In our group, I just finished a journal club or joint journal club with our fellows and residents an hour or two ago. So I had some spirited discussion with some of my partners around dual mobility and stiff spines, and I look forward to learning a lot. And I do give you a lot of credit, Ira. This is a tick up for Medline and PubMed. If they, the more they allow JOEI articles and JOEI to be, recognized, because you get a lot more out of discussions like this than you do out of reading articles that are generally biased.
Yeah. Yeah.
Totally agree.
Thank you for that. Thank you for that. So I'm going to start it off with a question. So I used to say that rotator cuff disease is all viral. It's a virus that's carried by a shoulder fellowship trained surgeon. As soon as they go into town, all of a sudden you see the rate of rotator cuff disease go up like Ebola. I'm beginning to feel that the use of dual mobility cups is a virus carried by young arthroplasty surgeons when they come to a town. Now, I may be wrong, and I'm certainly quite biased, not being young. So, Matt, what's going on with this growth of dual mobility, and is it proper? Well, what do you think about the growth? Have you seen growth in your community of it?
I don't know that there's been huge growth. There's been growth of it in my practice. I mean, I think this is something that we started to see in the U.S. 15, maybe not even 20 years ago. And there certainly have been more systems that have added that to their portfolio. So it's out there, it's being sold, it's being pushed. So I think you see some of that. This is all about context. And like you said, when should we be using this or not at all? And I think it certainly has applications. I think that a lot of people see the utility in revision scenarios. Certainly, I don't think many arthroplasty surgeons ever want to think about doing a constrained liner. It's been shown to increase stability in revisions. And so I think you see it there. And I think we're recognizing these patients with multi-level lumbar fusions, the stuck sitting patients with a flat back and a stiff spine, that I showed the paper in one of the OSET talks that won the O. Frank Award in 21. They had a less than 1% dislocation rate overall over about 4,000 hips, but overwhelmingly their dislocators were from that stuck sitting group. So there's a particularly high risk group of patients. And I think in that and revision scenarios, you're not going to see it questioned very much. And so the question or other questions are, when is it applicable in primaries? And that's, or in primaries in those not less high risk patients, maybe we should say. And I think that's the heart of your question. And certainly for most arthroplasty surgeons that are doing volume, dislocation should be rare, 1% and less, regardless of your surgical approach. I mean, we're expected to be facile at doing these and to have good results. But I think that everybody would recognize, whether they're yours or they're someone else's, that very small percentage of primaries, that that first complication becomes the first step in a snowball that, may turn into a disastroplasty later and wind up in one of Herrick Siegel's posts or something like that. So if we can obviate some of that group, then we may have done a good thing.
Brian, what's your feeling about?
I think you're right, Ira, when you talk about the viral and the viral of the youth, right? That's how it spreads. Because some junior person in practice is doing their first 10 cases, it's a dislocation. All of a sudden, they got a 10% dislocation rate. They're so terrified that their 11th, maybe their second dislocation, that when a rep comes up and says, we can solve that problem, it's been shown that we can get fewer dislocations if you put in a bigger head, and dual mobility is the ultimate in small people with a bigger head than the cup size you need to get to a large, ceramic femoral head or oxinium femoral head. They kind of get mesmerized by that, and then they end up doing the next 10 that way, because now the next 10 doesn't have a dislocation. So it takes them a number of years before they have enough patients that they sit there and say, oh, that's right, that was only 1% when I get to my first 100 patients. And then they can get back to more realistic with their primaries. I think it really is kind of a young person's problem. But there are certain indications for it, obviously, that, as Matt talked about with the stiff spine people, whether or not that's, more a large head is just as good as, dual mobility in that patient population, whether or not technology actually aids in decreasing impingement in that patient population. But that patient population in the stiff seated or stiff standing is still less than 5% of the total population of, patients that we see. So again, there's not a gigantic, all need to be done this way. But certainly there is a place in your orthopedic toolbox for a dual mobility. And I like it particularly if I'm revising a resurfacing from 20 years ago and there's nothing wrong with the cup. Doing a dual mobility into a perfectly good, well-shined, acetabulum is very easy, and gives you the stability, and you don't have to extract, an odd shaped cup out and put in a new acetabulum for that indication. So, and as you talked about before, people in the Bronx are not trusting anybody. I think there are patients, alcoholics that you don't really recognize totally to be that much of a risk. And, they're probably not an unreasonable patient population for this, or the neuromuscular people. There are, less than 10%, I would say, are really, ideal people, and 90%, probably are better off treated with conventional, hip replacements, both from a population point of view and for their own individual outcome.
So, question kind of remains, um, how do these indications tend to expand besides the young patients? Um, you have, all of a sudden you have people talking about, and Russ Bodner's brilliant, and I really respect his work incredibly. But I we didn't have an appreciation for a lot of the spinal pelvic stuff until Larry Dorr started talking about it, and Russ Bodner started pushing it, and brilliantly did a lot of research on it. Um, but I'm just trying to really wrap my head around the idea that I just haven't seen in my practice, and my approach is more anterior, and using big heads. I have just not have seen um, this this idea that we're dislocating as much as the literature seems to be saying. I mean, I mean, what's your feeling about that, Brian?
I'm with you 100%, Ira. But remember, 85% or 80% of the people in the world are doing a posterior approach in a
Yeah,
patient in a lateral position, and that lateral position is a flex pelvis, right? And if they're supine, you're now in a more of that, standing position, and the acetabular view is different and probably more appropriately viewed for these stiff spines. So I'm with you. I don't see this as a problem for me. I've also made it so that, my cups, aren't more than 10 degrees anteverted from an anterior approach. I literally make sure I ream 2 more millimeters so I can actually have the full face of the cup completely a millimeter or two behind the bony face. And, I leave half my inferior capsule there so I can kind of protect that glide pattern for the iliopsoas in that. And I make sure that the cups are, you know, down and square, using the TAL as the ligament, the floor, and the room. But if you're going to go back to my roots of doing a posterior lateral approach to the hip with a patient that is in some position, at some point, I like where they've gone with the technology, right? Because they have better understanding of where that pelvis is that we don't need because the patient is supine.
yeah. Excellent. Vincent Palmer, you had a question. Maybe you could unmute yourself and you could show your video or not and ask your question. Oh, Vincent? Okay, I will ask Vincent's question. Um, what can you advise a sales rep what to look for spinal pelvic tilt indicators on a standard x-ray that would suggest dual mobility? Who wants to take that one?
I think unless you're walking them through and doing a standing and seated lateral, which presumably they won't have when they're just looking at that. You're just looking one for hardware. I mean, would be the most obvious if you see fusion hardware, but I think if you see a lot of osteophytes, auto fusion around the facet joints, things like that, where you're going to have somebody with a stiff lumbar spine that you may see on the lower part of a AP pelvis.
Excellent.
I think I mean, and also the one thing to look at is when you don't appear to have your standard AP pelvis, when there is some torsion to it, like it doesn't have to be just in the AP plane, it can be in the coronal plane too, where if the pelvis just does not look normal on that
Yeah.
AP, be it a standing AP or supine, that's usually because there's some type of a lumbar or sacral, you know, um, addition to the equation. And then you still have to get back to cup positioning more than just dual mobility or large femoral head, because that should be the aha moment for a surgeon saying, this is one that I really want to pay attention to my acetabular. Well, you should always be paying attention to acetabular position, but in these cases, try to defend yourself against the instability patterns.
Interesting. Scott Lyon, you mentioned unmute yourself and explain DM Russ Bodner.
I think that's the explanation for what to do when looking at the X-ray.
Yeah,
Yeah.
I'm just saying if the rep wanted a full indication of when he should use dual mobility for his customers, DM Ruts Bodner, and then an hour later you'll realize you have no idea what you're talking about, but you can generally get the idea of some specific indicators for whether that's seated or flex seated versus standing, and the
Sure.
lumbar um, stability and stuff. So, but yeah, I deal a lot with Corn and their whole optimized positioning system. So I'm just very curious as to the whole spine pelvic relationship, and I have a customer of mine that uses dual mobility in all of his cases, modular dual mobility, and hasn't had any issues in a long time. He's been doing it for like 12 years, but it's just an interesting topic. So interested to get other surgeons' points of view, and don't know what's the better option, just large head or dual mobility or monoblock dual mobility, but um, there's more than one way to skin a cat. So
Scott, what do you do normally? What is your day job?
So I work with multiple total joint companies. Uh,
Okay, very good.
I'm in the vendor industry where do bone cement totals and other surgical equipment for various manufacturers. Yeah.
And a lot of surgeons, you've noticed, are expanding their dual mobility.
Yeah, the
In your
first
experience.
exposure I got to it was with a customer maybe about 8 years ago. They came out into practice out of fellowship. And he started doing it a little bit in his primaries with I was with Zimmer Biomet at the time. So we had G7 with the dual mobility come out and doing the range of motion with that just gave him such a feeling of belt and suspenders to Dr. McGrath's point when he first got into practice, probably afraid of getting some dislocations initially when he got out into practice. And flexes up to 90, it externally rotates to 45, 60, 75, 80, 90, and it would not pop out. And it just gave him a very good feeling. And then he kind of went back the other way, just went back to more normal 36 head usage. Um, but I think the popularity of the relationship of the hip spine relationship and focusing on that has really brought the dual mobility to the attention of a lot of surgeons, some of which some surgeons just have their blinders on and just do what they do and don't even really consider dual mobility as an option. And this kind of just brought it to the forefront, where I think that has exposed a lot of surgeons that might not have, not higher volume surgeons that do a lot of total joints and like, well, I don't do as many total joints. Maybe I'll just start doing this to protect myself and give my patients a better chance of not dislocating.
Right.
I think the usage in those higher risk patients is the gateway drug to starting to do it more often sometimes,
Right.
for better or worse.
But the one thing, Scott, I mean, you've been in this business for a while too. Everything that we do, we take one step forward in orthopedics and two steps back. There will be a number, like no one thought we are going to see all the metallosis that we see at this point in time. Alval was everything for about 8 years, which then got replaced with metallosis. And we will, if we get a high enough percentage of the patients out there having dual mobility with all those different bearing surfaces, we will have problems. The question is, what will that problem be? Right? And remember,
Right.
we're starting with something that's 97% of the time good or excellent in anybody's hands. And we've all seen hips that are going like, how the hell is that hip still in there? And the patient's walks in your office and it's been in for 25 years. And they're great. They're like, I'm coming in for my knee. Like, oh, okay. So clearly we can get away with a lot in hip surgery, a lot more than we can in knee surgery.
Yeah.
And it does have a role, but it is like Matt said, it's the gateway drug on that. If you look at population health on that, and there's a bunch of articles out there for cost effectiveness, it's only cost effective if you have over a 5% dislocation rate. And
Yep.
if you have an over 5% dislocation rate in your hip population, you probably should be doing something else.
Right. And in the industry standpoint, from the vendor standpoint, um, it's interesting that I've seen the cost discrepancies of dual mobility versus conventional total hips has really shrunk to where it's not very much of a big price difference at all, maybe a couple $100. So it's become a lot more reasonable. And maybe that's part of the reason too why more people are using it, because they're not being an outlier for the hospital administrators with using that component.
And in a lot of centers, there is no difference. It's in a capped price, and a hip is a hip, and you could argue that price is artificially pushed up if there are more dual mobility being done, and so it's being bid at a higher rate. But a lot of places, there's no price difference.
Yeah, unfortunately, in my location, there is. It's about $1,500 difference in our patient population that represent about $13.5 million of additional spend.
Wow.
And I've yet to see a company come in and actually decrease the cost of their implants. They just change it to rebates or something else within there that makes it look like everything's kind of all equal and rosy. They start talking about what the Medicare reimbursement is in your surgery center or whatever to make it seem like it's like you're getting something for nothing. But I mean, even if it was just that, even if its cost is the same, dislocation we're talking about, and we're really focusing in on the spinal, the hip spine patient population. that represents only 5%, right? So, why are we doing something? Because when they first came out, I don't know, it's probably in practice for about a decade when Doable Melody first came out about 21 years ago. And there was I had people across town started using it and saying, and trying to publicize the fact that it was a more comfortable hip. I'm like, uh, are you kidding? It's a bigger head. How could it possibly be more comfortable in there, especially when it has a square edge? And if it moves, it's going to irritate the iliopsoas or the posterior capsule and all those other types of things. Clearly, it was that nonsense was pushed aside within 3 or 4 years, but it was something to contend with too. When patients coming off and saying, "I want to do a mobility hip because I hear they're more comfortable," like, well, they're not. But there are advantages like we've talked about, and people should have it in their toolbox because there are definite indications for it, but in a very small percentage of patients.
So we have a question, John Desjardins. John, you want to ask your question, please? Or not? Okay.
I'm sorry, I'm in a loud environment and a little
Oh,
dark
that's okay,
in
John.
my backyard. But I just wondered how the panel felt about putting in a cobalt chrome liner versus an inert liner versus, like an oxinium or a ceramic liner versus cobalt chrome, which I think, I mean, I'm just a rep. I don't know anything, but I think cobalt chrome is just kind of like a disaster in my view, but that's just my modest opinion. I'm sorry. Thank you for letting me speak.
No, it's great. That's an open mic. Like, Matt, what do you think? Cobalt Chrome, what's your use?
Yeah, so I mean, I think that's been a concern all along, and I think to Brian's point, the last cycle of this, the thing that was going to solve everyone's dislocation problems was big head metal on metal, and it was a disaster. So I think that there's at least a cognizance of that this go round, and so you have cobalt chrome, but you've also got monolithic, at least for use in primary, which sort of obviates that interface entirely. I know Medacta uses their Sensitin. Guess that's a coating or preparation on the back side of the modular metal liners. Oxinium, you've got sort of these alternate bearing surfaces to avoid that cobalt chrome on titanium interface that we're starting to see from at least some of the manufacturers. So I think people are aware and are looking at it.
And Brian?
For however helpful that is.
Yeah, very helpful.
Yeah, I think Smith and Nephew was late into the market, and their reason was to see what they could do with the difference between cobalt chrome and oxinium, which is the way that they've gone. And I think even Stryker now they have a ceramic head now that is maybe not fully commercially available, but it is, if it isn't available in everybody's market, I know we have it here, that it will be, soon. But it gets back to the same point. If you put a small femoral head, to me, it almost like a drill point. Where exactly is that going to go, and at what point in time does it, find its way through, these bigger heads that aren't really that much bigger and that much thicker poly, and they have a very, directed, position towards, really carving up the polyethylene, and we haven't seen it long enough. That's the thing that I always harken back to. We think everything works in the lab. For God's sakes, we had carbon fiber in tibial components when I was a resident, and then from Zimmer, and inside the knees turned black. It's just like we've made
those, yeah.
all kinds of mistakes, and we don't see it until it's been out for a while, or until there are enough out there that the relative percentages start tipping it over, and you say that's not a problem that we need. So I'm always kind of the tip of the spear when it comes to innovation, trying new stuff. I grew up as an orthopedic oncologist, always having to fix really big holes, and but sometimes you just don't need to make things more difficult, or try to find another way of having a different complication 5 or 10 years from now.
That's interesting. I'm going to switch gears slightly and talk about the use of dual mobilities for revision surgery. Okay, and the idea of their use to prevent re-revisions, if that's such a word, re-revisions. Um, I want to bring up an article I found. I really apologize to everyone for actually reading. Okay. Um, uh, I think that I share my screen. I did not share my screen. I'm going to share my screen right now. Here we go. In a journal I never heard of, Journal of Orthoplasty. Okay. It's not JOEI, but it'll have to do. Um, this was an outcomes of dual mobility versus fixed bearing in revision total hip, a systemic review and meta-analysis, which are always very difficult for me to read sometimes, um, because their results, they talked about that the DM implants had a lower odds of re-revision and an odds ratio of 0.38. So I just want to point out how difficult these articles sometimes are to read because, you know, I don't know if how many of you think in terms of odds ratio. So I had an idea that I was going to ask Chat GPT the following question. This was the odds ratio, which I can't make heads or tails of. So I said, based on this, for every 1,000 events, how many more re-revisions would occur in a primary arthroplasty versus a dual mobility? Okay. And this is the calculation that ChatGPT did in seconds. And essentially, the conclusion, which I don't know why they don't say this in the articles, they just say the odds ratio. But the conclusion is for every 1,000 events, there will be 60 more re-revisions if you didn't use a dual mobility. That was their systemic review. All right. So using that as a line, so you do 1,000 of these, 40 40 would dislocate if you had dual mobility, and 100 would dislocate if you had a non-dual mobility cup. Okay, so is that enough of an argument? I'll stop the share right now, but this is, obviously everyone could do this calculations in their sleep. It's pretty easy. It's not a big deal. So anyway, so with that said, is 60 dislocations in 1,000 enough for Herrick Siegel to use a dual mobility every time because all he does is revisions and or do you use revisions? Do you use dual mobility on all revisions? Is this an argument for dual mobility for all revisions? Matt?
I'm probably close to dual mobility in all revisions, and I would throw that out to the industry folks on the call and ask what they're seeing. I think that has certainly become more common, and for those of us that do it, and dear God, I mean, for none of us is it like Herrick's practice, but um, those are bad cases that turn into more bad cases. I mean, the re-revision that leads to the re, where you're on the fifth or sixth one, and
Yep.
at some point you roll snake eyes and it's infected, and it just keeps going. Uh, that's going to make a difference for the system if we can reduce those cases.
Yep. Yep. Brian, your thoughts?
Yeah, I mean, one reason you don't use meta-analysis and then try to calculate what the true numbers are is because the meta-analysis is based on eliminating 70% of the articles that had anything to do with it, but they just didn't happen to be looking at what you're looking at.
Right.
And there's a ton of inherent bias of trying to look at a bunch of math and then discern what you want to discern from it and make the point or make some point, because if you didn't make a point out of it, you couldn't get published. But that being said, revisions are a multi-splendid thing, and femoral side, acetabular side, dissociated pelvis, protrusio, all those things where you need to do something on the acetabular side just to get the offset. The concern about doing all, thinking all dual mobility makes a difference is offset, and the ability to get the, appropriate tensions in your soft tissues. Granted, all things otherwise being equal, certainly large femoral head or dual mobility, adds to that. There was a Journal of Arthroplasty article that we just reviewed tonight, in that they looked at the, hip spine stiffness, and show in the beginning of their study, they were doing all dual mobility with a almost 6% dislocation rate, all being all Mako. And then they went to 70%, femoral heads 40 or bigger, and dropped the dual mobility down to about 30%, and their dislocation rate went from 6 to 1.5%. So it's not all the surface or the size of the head. It's a soft tissue balancing. So it depends on what you need to do to make that up ultimately. But I think, like the question was earlier about what does the rep bring in the room, right? You bring enough stuff in the room so you can use large femoral heads, small femoral heads, dual mobility, offset liners. I mean, and because you get in there and you need to get some sync often just to be able to arrive at something that is stable. And dual mobility makes it a little bit easier in that regard too for your stability, and especially if you have some soft tissue defect in your abductor mechanism. So, but in my revision practice, I use dual mobility very little for revisions. More big femoral heads because of their big acetabulums or double bubble cups and three-dimensional pelvic reconstructions for bigger tumor cases.
Interesting. I'd like to call on Raul Gust. You had two comments. One about the cost effectiveness. Maybe we could flip to cost effectiveness for a little bit. Raul, could you
Sure.
unmute? Yeah, thanks.
Anyways, I'm at a restaurant, so I don't know if you want to see the video of me having a bowl of soup in front of me, but
No, we're cool with that. We're cool with that.
yeah, let me just get on it then. All
Hey.
right. So as far as the cost effectiveness, there was a paper, I can't remember where it was. It was in, I think, Journal of Arthroplasty, or JBJ, or Bone and Joint Journal, I think, that looked at cost effectiveness of dual mobility in revision settings, and found that because it lowered the risk, to your point, to your ChatGPT question, because it lowered the risk of revision, it was actually a cost-effective measure to the system, right? Albeit that one patient's care might be more expensive because they have dual mobility bearing, but to the system overall, it'd be a lower cost. So I'm a believer of it in my high-risk patients, my revisions. If I'm doing like a cup and cup construct, I'll try to get away with a monoblock, and I cement a monoblock in there, get a larger effective head. I think it's a nice reconstruction. But I don't have any qualms about putting in a dual mobility, even a modular dual mobility in the right patient. Yeah.
That's a great point. To talk about Brian's point though, about when you get creep on this a little bit, where more people are using it, they saw $13 million in expenditures. I know that's just a slow month for a out-of-network spine surgeon, $13 million. But for us regular folks, that adds up. So I think you're right, 100%, Roval, that it's cost effective when judiciously used.
Yeah.
And maybe I'm kind of spanning the fence a little bit with Brian's comment, because when I was doing revisions, I passed those on to younger folks, like people like Matt. But when I was doing revisions, I rarely used the dual mobility, but there were cases, especially I think you pointed out, when you're doing a re-revision rate for instability.
Sure.
And you've inherited that case. And I think that was a very good point, Ro. Where are you in practice?
I just recently relocated. I was in Fort Lauderdale, part of Holy Cross, and the fellowship down there. And then now I just moved to Denver 6 months ago. So
good for you.
starting from scratch after 8 years in practice. So that's fun.
It's always a good challenge.
Yeah.
There's a lot of yeah, Aaron Hutchinson just said, hope
Oh,
you're
yeah.
liking Denver. It looks
So,
like you're liking Denver. I don't know. It just
yeah. Yeah.
looks like
I'm
you're
having a nice spa.
yeah. John also asks, would surgeons cement the DM in? Would you cement it?
Uh, I I do all the time for like complex revisions. I'll cement a monoblock shell quite often.
All right. Very,
Do
very
you
good.
do any rebar into your cement when you're doing that,
So if
or
I
is it
if
for
I'm
the
cementing
surface
into like
tissue?
a if I'm cementing into like a TM shell, where I've got the
Okay.
TM shell and then I cement into that, I won't use any rebar screws. Yeah, I guess if I'm cementing into like a native acetabulum, I might just use a polyethylene. I don't typically cement. I'm just a I have as a s- I have, but I'd rather not.
I just wasn't sure whether you're talking about acetabulum deficiency or whether or not you're talking about a stable cup from a previous surgery.
Oh, okay. No, I meant more so in the like a 3B, Popovsky 3B, where I'm using multiple cups to reconstruct, to bring the hip center down, and ultimately a large TM established shell, cement a magnum or a monoblock dual mobility into that construct.
Very
And
good.
when you're doing that, how are you deciding your offset? I mean, do you take intraoperative imaging to decide how far you've moved that acetabulum either medially, if it ends up staying medially, or laterally? What are you doing for that?
Yeah, it's a great question. So I do most of my revisions anterior. So I've got fluoro in there and I've got immediate feedback, immediate sort of evaluation of my offset. I find that although I'm pretty good at getting my leg lengths and my hip center down to where it should be in a leg length perspective, I find that if you're using multiple cups, you oftentimes end up increasing the offset slightly on that patient, at
But
least
you're
in my
using,
hands. Yeah,
but you're using the C arm to look at that, and then
I
that's
am.
what's nice. That's what's nice about dual mobility. You can really dial down your offset from that portion and
Yeah,
still maintain your stability. So.
yeah, absolutely, absolutely.
So, John McDonough, you had a question about the percentage of your peers and X-rays. You want to ask that question, or I'll read it out for you.
Yeah, sure. Thanks again for it's just sort of creating this forum. I think it's really good. I appreciate everything you do and including us. But Dr. Barber had mentioned the getting lateral and flexated X-rays, and I'm just curious, like, how routine is that? Maybe you see existing spinal hardware, maybe you see existing evidence of, spinal auto, fusion, biological fusion. How often are people routinely getting lateral, standing, and flex seated X-rays to try and get a sense of the those patients that might be at risk and might be good candidates for dual mobility constructs.
Um, Matt, you want to take that, and we'll
Yeah,
go
I mean,
around the horn.
I don't know how routine that is for how many people. I mean, it's just a question of if you've kind of gone down that rabbit hole with Russ Bodner and tried to learn it. I think some of the options, IntelliJoint has made View basically open access to be able to plan with that. I know was it Scott or somebody mentioned Corin OPS, which I think is CT based, so that's a little different. But there are options out there, and I don't know how many people are availing themselves of it. That's a case where you're not having to recognize it because the surgeon's kind of already done that work and that planning.
Brian, you have quite a few partners there now in that arthroplasty group. Um, to answer John's question, how many are routinely looking at that potential 5%?
About half my partners, we bought a new EOS, X-ray machine.
Yep.
So it's basically a standing CT scan. And so they're getting them on all their patients. I get them on none of my patients. As Ira, as we talked about before, my patients supine on the table, and the acetabulum is pointing one direction or another, and there's a stiff spine, and I match that, and our dislocation rate is 0.2%, 0.2%. 1 in 500 patients find a way to dislocate, falling down the stairs or doing something fun. I hope it was fun when they dislocated.
Yeah. Yeah.
Sure as hell don't seem like it in the emergency room, but something beforehand. You often smell of alcohol, so that's a good thing. But my other partners who are big into technology now are always doing that. The interesting question would be, and this is what I love about your forum, Ira, and I hope this becomes totally viral. I mean, I know it's grown a lot, and I hope it goes a lot more. Remember, 80% of hip replacements in the United States are done by people who only do 25 a year, right?
Right.
So, some of this, the easy button is always something that they go to, and I think you probably will see more dual mobility in the hands of them, and maybe that will be a good thing, or we're going to generate a whole new bunch of problems out of that. But none of those people have EOS machines, and none of them are looking at, or very few have I guess the foresight or enough partners around them to start, banging away about how you need to pay attention to those patients. But it does bring up the benefit for the reps and everything like that, because, Matt, you and I sit in the hospital, and we're going to do, 30 joint replacements in a day in the hospital. Not me, but all of the partners around. There's something like that. They're doing a bunch of joints, and you have a certain amount of camaraderie and understanding of what's going on, and getting pushed towards technology. But most other people don't have that, and they rely on the reps in a big way. And I know, looking down the list here, there are a number of reps on here, and I applaud them for jumping on a call and talking about this and trying to learn something about how they can help their surgeon through things. And I would suggest for them then, and something not in my own practice or in my own partners, but for those people, having the dual mobility in your bag will save a lot of people a lot of trouble.
That's a great point, and a great lesson to our partners in the OR, the reps. We do have a LinkedIn star, Kevin Brown, box opener extraordinaire. Kevin, you had a question. You want to unmute if you're still on, Kevin? Oh, you are on. Yeah, unmute, Kevin. We want to see your face. Okay. Anyone worry about the modular DM metal interface, or it's just his OCD? He said, Kevin. The modular DM metal interface. We worrying about that long term? Is that the 800-pound gorilla in the room?
Of course, you'd be crazy not to be thinking about it, and watching those.
Yeah, yeah. Brian,
Can I? I'm
yeah,
sorry.
yeah. John, go ahead. John, go ahead. Yeah.
I'm sorry. Just to
Why do you apologize? Great.
Just to just wondering why you would use a cobalt chrome liner versus some inert like Medacta, and Link has Porex, and obviously Smith & Nephew has Oxinium. Why would you put in a cobalt chrome liner I've seen, I've been a rep at Rush for 30 years, and I've seen a lot of revisions with metallosis on a cobalt chrome backside. I'm just curious, is it just G7? Because the G7 cup is a great cup, and it's a phenomenal system. Just wondering why you'd want to do cobalt chrome. That's all.
So, John, are you talking about the acetabular portion of it, cobalt chrome, or an oxinium? Or are you talking about the femoral head?
No, the backside wear of the liner.
Oh, not of the trunnion, but of the metal on metal. But you're talking about the poly on the metal articulation of the acetabulum?
No, the metal liner and the
The
backside.
interface between the liner and the cup.
Yes, sir.
Oh,
Yes,
okay.
sir.
So you're talking about, I don't have a good answer for that, other than the fact that I've seen ceramic on ceramic go to hell pretty quick. And then what do you do when you have the ultimate solvent in the joint and in the patient? Because when those go bad for whatever reason at any point in time, you can never eradicate that.
Correct.
There are some beauties of metal because although they may develop metallosis from some backside wear or corrosion or whatever term you want to use, they don't shatter and become, you know, the ultimate little debris in the joint that you can never remove. So that would be the only reason, but otherwise I don't disagree with your point. But my bigger concerns are what's going on between the trunnion and the inside, or if you're going to use a monoblock, even whatever liner or whatever Morse taper they have between the all poly and the trunnion of the stem. Those are the parts that will be the issue long term. You're talking about a massive side. Remember, we put bipolars in for a couple of decades, and everybody's that's great because there's multiple faces of articulation, but it was soon found out that there's only one thing moving in a bipolar, and that was the metal on the cartilage, because right after as that patient's healing, that inner bearing is becoming, basically useless or stiff.
Right. No, I totally agree. I'm just a rep, but I've seen a lot of corrosion on the backside of the metal, the cobalt chrome liners in the dual mobility, and I've had a lot of experience with BHR, with Dr. Delavalli.
Yeah. So, it's a great point, John.
I don't know.
You really have great experience, at a Rush, and it's great to have that voice. I used to have a line. You asked a very important question. Why would you ever use? Right? That was a great question.
Exactly.
And I remember Jeff Rubin out of Texas used to say, the first 5 years you come out, you use it because that's what you use in your fellowship.
Absolutely.
The next 5 years, you use it because of the rep. The third 5 years, you use it because you know the designer surgeon. And the last 5 years, you use it because you are the designer surgeon. So it just brings up a lot of motivations. It is mind-boggling that, you can see a paper that's so obvious that says something, and then people are not going to change from what they're using because there's a status quo. I have seen that, in a number of hospitals I've been at. Matt, what's your feeling about implant choice changing? How difficult?
Well, so maybe that gets back to what there's a crossover with Brian's point about lower volume surgeons that are a lot of what they see is controlled by maybe one or two reps. And so maybe they're using it because that's what they now know exists that they didn't know about before, that has potentially assisted with their dislocation concerns. And so, it's a miracle. And they haven't really thought that through and don't really know that there are alternative surfaces available.
Interesting. Brian?
Maybe why, maybe people aren't seeing a lot of issues with it. I certainly believe that at least some percentage have to have it. I would also guess that if you're at Rush, there's a selection bias where, they're catching a lot of the most difficult cases in the Midwest that are gonna funnel in there.
Yeah.
That makes a lot of sense.
Yeah. My question for you, John, is I always beware of the N of one and the statements that I've never seen it before, or I see a lot of them, because frankly, most surgeons will never do something that goes bad the first time. It's like putting your hand on a stove, right? You're not going to do that again, and you're going to try and find something else. But most things that we look at out there, you have a failure rate that's less than 10%, regardless of what we're looking at. But it completely changed the landscape of what we're doing for the next 10 years. So back to your question about, cobalt chrome. I mean, we look at it as the devil at this point in time, but it was the workhorse for a long time. And I see patients 25, 30 years out coming in with old Charlie stems, or 40 years out with an old Charlie stem in. No way that should still be working. And yet 60% of those at 45 years out are are still very successful, and that's only because the remaining people already passed away, right? Um, I think that there's a lot of good in cobalt chrome. I think it's got a real black eye, not to use it, too much of a pun there, but we use cobalt chrome femurs on polyethylene every single day, right? I mean, there are a lot of uses for it, so I don't want to throw the baby out with the bathwater here. Yeah, but there are better surfaces. I'm with you, but each one of them will have a problem along the way. And for the number of cases that we're actually going to use dual mobility or suggest it should be used in, hopefully we don't see, a waterfall of, problems 10 years from now.
I agree with you, sir. I
But,
mean,
Well, and so that
humbly, I'll say that very humbly, as just a sales rep, I have a lot of experience with BHR, and I've seen a lot of great results. So I'm not going to say cobalt chrome is the worst thing in the world. I just was curious. That's all.
yeah, but have you noticed that? I mean, when you do that, I mean, this is a totally, going down the rabbit hole of BHRs. The only thing I found, like I did probably 300 or 400 of them back, and they're
Wow.
now 10 and 15 years out. Um, but when people come in for their other side and you say, oh, we're not going to make that big operation on you, you're 15 years older, blah, blah, blah. They're almost always happier with their total hip with
Mhm.
ceramic on poly than they are with the other side. They don't want anything done on the other side, but they go, yeah, this one does feel better. Have you noticed that with your surgeons?
Well, I'm extremely biased because I was with Smith and Nephew for 25 years and did a lot of BHR training and things like that. But now that I'm 56 years old, I'd probably have a total hip now instead of a BHR. But if I was 40 and I was a big guy, then maybe. But that gets back to the metallurgy of cobalt chrome. And I think if you do it right, you got clearance and you have the things that make BHR great, I think it's a really good operation. Humbly, I'm not a surgeon, but I think I've seen some really great results, 20 plus years. But right now, at my age, I probably have a total hip, anterior total hip. That's what I would do. And I wouldn't want dual mobility.
Yeah. So we're as most open mic sessions.
Sorry, guys.
No, no apologies for anything. This is great. We are at 2 minutes to 9. So as most open mic sessions, they go by so much quicker than we expect them to. And all good things come to an end. So I'm just going to ask Dr. Matt Barber and Dr. Brian McGrath to sum up a couple of points. And Matt, you'll start off, and Brian, you'll take us home. Matt, a couple of summary statements if you want, or
I'm going to add to your list of the influences of choosing implants, even more so than those things that you described were probably all influenced the most by our most recent complication.
yeah.
So whatever that was, if it was dislocation or if you saw metallosis or whatever it was, but I think these do have a role. I think if you're using them in primary, it's become very intriguing to me to do that with a monoblock component and just get that metal interface out of there. There's still questions about whether these might become dyskinetic, as David Kerwin says, and whether there's notching or impingement on the stem and what the consequences might be of that. But I don't think it's going away. So we're going to see what role it settles into.
And Brian, you want to say some final comments, please?
Yeah, I mean, remember that 97% of our patients, in which total hips specifically, are doing good or excellent, and for decades with all the horrible materials we use and all the good materials. I certainly believe that dual mobility has a real role in at least 5% of primary hips, and maybe a slightly larger percentage in revisions. You just need to I think utilize your technology judiciously and think that fewer bearing surfaces are often better than almost anything in your car that goes bad. or anything you ever see, when it has too many different interfaces in it, it leads to a problem. And that's my biggest concern. But I do think 80% of people out there doing less than 30 joint replacements in a year, and probably half of those are knees, so even less in hips. This is a product that will help them get through and not have a big problem. And hopefully, with your wisdom on first 5, second 5, and third 5 years of your career, even in the hands of people who do that few, will gravitate towards more conventional single articulations.
Great. I just want to comment that David Kerwin was supposed to be here. He direct messaged me on LinkedIn and said that he was had a court appearance and he would be in contempt of court if he came on the JOEI open mic. I told him, unheard of, go to jail and join us from jail. So I'll leave. That's how important JOEI open mics are.
Seems his priorities are wrong, doesn't it?
Yeah, absolutely, Marty. I just want to make a final comment. Orthopedics lost someone recently, Dan Dysart, who was a great surgeon out of Georgia and was a chief medical officer of Pacera. It was a great loss to the orthopedic community. I just like to mention that, and a good friend of the journal. I want to thank everybody sincerely, Matt, Brian, Raul, Kevin, John, Aaron, the whole group, Patrick, you too. There you go. Everybody. This is what open mics were all about. And it was a great session. Matt, thank you so much for putting on that LinkedIn post and making it go viral. And I'd like to say goodnight to everybody.